Or my rat.
Way too close.
No,
Benji.
on my ground.
That was not okay. What the fuck?
Stop it.
Hey, Manan, keep quiet.
Mother.
What the fuck?
We don't want to see what you're doing, Akash.
Apologies.
Wait, class is at 5:30. Come back later.
Marrow. Yep, tumeanza. Hi, bye. I'll call you once it's over.
Is it?
Good evening. Hello.
3,5 GM-CSF and lipid mediators like eosinophils, LTC4, LTB4. Eosinophil can provide CD4 T ligand and interleukin-4 for B-cell activation.
Good evening. I'll be talking about the spleen this evening, and we'll talk about splenic enlargement, hyposplenism, and also hyposplenism, because we do also come across situations where the spleen becomes atrophic. So I'll go through the basic anatomy and physiology of the spleen, and then talk about the pathology of the spleen. Now, spleen has an important role in hemostasis, and it's also an organ which gets affected by both hematological conditions as well as non-hematological conditions. And as a hematologist, we often get consulted to review patients who present with splenic enlargement. Splenomegaly is an important clinical manifestation of many of the hematological disorders, especially the myeloproliferative disorders and lymphoproliferative disorders. But there are other non-hematological conditions which present with splenic enlargement. And therefore, it's important to have a thorough physical examination, get a good history, and order the relevant diagnostic tests when we are evaluating a patient with splenomegaly, and to find out the correct cause of his splenomegaly. Assessment is important because it helps in diagnosis, and there are the hematological disorders in which splenic involvement is an important criteria for staging. And once we have made a diagnosis, then we need to find out the best protocol for managing these patients. Taking you back to embryology, you are aware that the spleen is derived from a mesenchymal stem cell, and it is formed in the first 2 weeks of conception. The mesenchymal cells will then differentiate into reticulum cells and the pluripotent stem cells, as well as the colony forming units. Now that's basically the beginning of hemopoiesis in the fetus. So within 2 weeks, these cells are active in producing the white cells, red cells, and platelets that we see in the fetus. And by the 3rd month, it has become a fully fledged hemopoietic site until birth. And after birth, the function of the spleen, the hemopoietic function of the spleen regresses completely. However, in certain hematological conditions, the spleen can revert to its role in hemopoiesis. And in these conditions, some of which I will be mentioning, the splenic enlargement is because the spleen now becomes a site of hemopoiesis and it enlarges. So we have that at the back of our mind, that under certain situations, the spleen can revert to its function of hematopoiesis after birth. The normal weight of an adult spleen is between 150 to 300 grams. At puberty, it is 200 to 300 grams. And after the 6th decade of life, it shrinks and it weighs between 100 to 150 grams. It has a length of 8 to 13 centimeters and a width of 4.5 to 7 centimeters, with a surface area of 45 to 80 centimeters square. Its volume is 275 cubic centimeters. Once the spleen length becomes 14 centimeters, then it becomes easy to palpate the spleen in the left hypochondrium. Sometimes we get massive splenomegaly. I'll be mentioning those conditions where the spleen gradually enlarges and can be felt into the right iliac fossa. That is massive splenomegaly. And in some of these conditions, when the spleen is massively enlarged, it can weigh more than 2 kilos. So those are the statistics of the spleen, normal spleen. So when the spleen enlarges, then its weight is going to be more than 500 grams. In massive splenomegaly, it's more than 1 kilo. In terms of size, moderate splenomegaly is present when the spleen size is determined either by ultrasound or by CT scan. If the spleen length is from 13 to 20 centimeters, it's moderate splenomegaly. And when it's severe, it's more than 20 centimeters. It has an important role in immunity. It is one of the major organs that provide immunity in adults, and it's required for clearing of microorganisms and antigens. There is synthesis of immunoglobulins and complement molecules in the spleen, and it also functions to remove abnormal red cells in circulation. And as I mentioned, that the spleen can revert to its role of hematopoiesis in adult life under certain circumstances. And we call that extramedullary hemopoiesis, extramedullary hemopoiesis. And there are functions in the spleen which help carry out the various functions. There is sequestration, there is phagocytosis, and there is pooling of the blood cells into the spleen. For example, about 1/3 of circulating platelets are pooled in the spleen. And when the spleen enlarges, then the amount that is pooled into the spleen increases. Structure is quite complicated. It has an extensive connective tissue framework with numerous vascular channels. There is lymphatic tissue, there is lymphatic drainage channels, and there are various cellular components in the spleen, particularly of the reticular endothelial system. There are two types of splenic pulp that we see. There is white pulp and red pulp, and there is an intermediate marginal zone at the periphery, which is basically the white zone blending into the red zone. So that's the structure of the spleen, which you are very
Dr. Dave?
My apologies. My internet went out. So coming to the structure, it's a complicated structure with several different functions. Essentially, we have an extensive connective tissue network, which is supported by vascular channels, lymphatic tissue, and lymphatic drainage channels as well. And we have the cellular components of the reticular endothelial system, principally the splenic macrophages and other supporting cells. So there are two areas that we see under the microscope of the spleen, the pulp areas. There is the white pulp and there is the red pulp. And between the two, we have an intermediate marginal zone at the periphery, blending from white to the red pulp. So this is part of your revision for from your anatomy days. You're aware of the structure. This is just a representation of the spleen under the microscope, where you have the red pulp and the white pulp, central arterioles, and the B and T lymphocytes in a concentric manner in the white pulp. Then a marginal zone between the red pulp and the white pulp. and the usual arterioles that bring in the blood supply to the spleen. And of course, there is a capsule that surrounds the spleen. So there are these functions of the spleen. First one there is sequestration, which is a reversible process. And what happens is that the cells get trapped in the sinusoids and they come into contact with the reticuloendothelial cells while traversing through the sinusoids. The other function is phagocytosis, which is irreversible. And the splenic macrophages play an important role here in engulfing particulate matter, non-viable cells of the hemopoietic system, and other cells which have been damaged by prolonged sequestration or by antibodies coating. So here, when the spleen is enlarged, the transit time of the cells through the spleen is increased. And because of that contact, the increased contact time with macrophages, they do get damaged and are removed from circulation. So an example here also is autoimmune hemolytic anemia, where we have antibodies against various red cell antigens present on the red cell membrane. And when these red cells, which are coated with antibody, when they pass through the sinusoids, they come into contact with the splenic macrophages, which recognize the Fc portion on the immunoglobulin molecule and engulf the red cells. They start destroying the red cells. So an important function, phagocytosis by the spleen. Then there is this pooling function. 1/3 of the circulating platelets are pooled in the spleen, in a normal spleen. And the amount of platelets that are pooled in the spleen increases when the spleen is massively enlarged, causing thrombocytopenia. So in certain conditions, there is engorgement of the spleen with the increased amount of blood. And this is in continuous exchange with the circulation. So those are the three principal functions of the spleen. So we'll now talk about splenomegaly and hypersplenism, keeping in mind the functions and the anatomy that I had earlier talked about. And one of the important important parameters that we are looking for in an abdominal examination is to see if the spleen is enlarged. And this is a frequently seen phenomenon, an enlarged spleen, and is an important clinical sign. So if we look at broadly what would be the causes of splenomegaly, broadly speaking, splenomegaly may arise because of a reactive increase of white pulp in inflammation and infection. So a number of autoimmune diseases, various types of parasitic infections. The white pulp is hyperplastic, and parasitic infections like malaria, like leishmaniasis, are associated with an increase in white pulp and consequent splenomegaly. Then we have congestive expansion of red pulp because of increased blood flow. The pressures, the splenic pressures may increase due to a number of reasons, and that causes expansion of the red pulp. We may have increased blood pool within the spleen, increased macrophage function, either due to infection or inflammatory causes again. And then we may have proliferative cellular infiltration. So the leukemias and the lymphomas would would be included in this group. I did mention extramedullary hemopoiesis. So if the spleen reverts to its hemopoietic function, then it will definitely enlarge. And then there are various types of storage disorders. I will give you a list where we have these molecules engulfed by the macrophages, and they proliferate in many of these conditions. And then we can have cysts within the spleen. A good example here is hydatid cyst, the dog tapeworm, the canine tapeworm, or Echinococcus granulosus, which presents with cysts. And we can have other type of benign cysts also within the spleen. And various solid tumors may also arise in the spleen. So that's a broad overview of what can cause splenomegaly. And then we can look into the various disease entities, malignancies, lymphoma. The spleen is regarded as it's like a lymph node, basically. Even if you look at the structure, resembles that of a lymph node. So you can have a lymphoma that arises from the spleen, causing splenic enlargement. In acute and chronic leukemias, principally in chronic leukemias, chronic myeloid leukemia, we have massive splenomegaly. Chronic lymphocytic leukemia, we have massive splenomegaly in late stages of the disease. Then there is a group of disorders we call myeloproliferative disorders. Myeloproliferative disorders, they're not really leukemias. They are classified as non-leukemic myeloproliferative disorders. And the example there is polycythemia vera and essential thrombocythemia. We will be having specific lectures on all these disease conditions, and we'll talk more in details about these when we come to them in your hematology lectures next year. Infections, various types of infections are known to cause splenomegaly. So viral hepatitis, Epstein-Barr virus, EBV virus, cytomegalovirus, in typhoid infection, brucellosis, and disseminated tuberculosis. We get the classical granulomatous infiltration within the spleen, and the spleen enlarges. Parasitic infections, malaria, schistosomiasis, not directly, but because of portal hypertension, increased pressures in the portal circulation, and we get a congestive splenic enlargement. In infective endocarditis and in disseminated fungal infections like histoplasmosis. Various types of inflammatory causes, especially autoimmune diseases, and this includes sarcoidosis, serum sickness, SLE, systemic lupus erythematosus, rheumatoid arthritis. So patients with rheumatoid arthritis, in addition to the typical joint changes, may present with splenomegaly, and that is known as Fat-List syndrome. Congestive splenomegaly we see when there is portal hypertension or when there is increased backflow. So in liver cirrhosis, we get portal hypertension due to schistosomiasis, and in congestive cardiac failure, again, the spleen may enlarge. Then the non-hematological infiltrative disorders, non-malignant, we have Gaucher's disease. These are storage disorders, and glycogen storage disorders, other amino acid inborn errors of metabolism, diseases like Niemann-Pick, amyloidosis, Langerhans cell histiocytosis, hemophagocytic syndrome, and lymphohistiocytosis. It's a very huge list of these conditions, non-malignant infiltrative conditions, where we have proliferation of the macrophages in the splenic architecture, causing splenic enlargement. most of these, the Gaucher's, Niemann-Pick, and glycogen storage disease, the macrophages are engulfing the products which arise because of a block in enzymatic activity. And then we have the other non-malignant hematological conditions, like the hemolytic anemias, autoimmune hemolytic anemia. I mentioned to you, we'll talk more about it when we come to discussing autoimmune hemolytic anemias, chronic hemolytic anemias, and sometimes after we use these growth factors, colony stimulating factors, GCSF, which is available for therapeutic use. Sometimes when we use that, we may get a bit of proliferation of the monocytic components, including the macrophages, and it may present with splenomegaly. This is not a very clear slide, but often when you will be doing your clinical rotations, and when you are also working as doctors, there are 5 conditions that you really need to know, which are which cause massive splenomegaly, and that's when the spleen is more than 1 kilo. And top on the list there is visceral leishmaniasis, Kala-Azar, chronic myeloid leukemia, myelofibrosis. In myelofibrosis, the bone marrow gets replaced by fibrous tissue, and therefore the hemopoietic capacity of the bone marrow in myelofibrosis is grossly restricted. And in that condition, then the spleen takes up its role of producing the hemopoietic elements. So you get extramedullary hemopoiesis in myelofibrosis that causes massive splenic enlargement. And then chronic malaria, in chronic malaria, there is proliferation of the macrophages due to persistent antigenic stimulation by malaria antigens, and the macrophages will proliferate, and when the infections are continuous and progressive, especially in malaria endemic areas, then many of these patients will present with a spleen which weighs more than 1 kilo. And then when we have lymphomas that arise from the spleen, there are a number of B-cell lymphomas that can arise from the spleen, and these patients can present with massive splenomegaly. So these are 5 conditions that you must have at the back of your mind when you are seeing a patient with a massively enlarged spleen. Many of these patients, the spleen will be will cross over from the umbilicus into the right iliac fossa. So how does splenomegaly present? It's surprising that sometimes you find patients who are not aware that have an enlarged spleen, but when you take their history, yeah, they will complain about vague abdominal discomfort. There may be referred pain to the left shoulder, early satiety, because the spleen is an enlarged spleen will be pressing on to the gastric region, the stomach, and then these are patients who take small meals and they get full very quickly. So we call that early satiety. So they have small meals, and because of that, they have early satiety. And then we may have signs and symptoms of the underlying disease. So when you see a massively enlarged spleen, you do a full systemic examination and look for other signs. Fevers, pallor, dyspnea on exertion, that's in the history. Petechiae because of low platelets. When there is jaundice, you can think about autoimmune hemolytic anemia, or you can think about a liver disease with cirrhosis. So there will be other signs and symptoms that you need to elucidate, which will help you come to a diagnosis. So a good physical examination is important when you elucidate a massively enlarged spleen. So again, history is important. You must take a very good history. And by taking a good history, you're thinking about all the causes that I've mentioned at the back of your mind. So your line of questioning in history taking will be based on what we are looking for. So take a history of the possible cause. Is he from a malaria endemic area? Is he from an area where leishmaniasis is endemic? Are there any systemic symptoms like weight loss, fever, night sweats, and so forth? History of contact with TB, that's all comes into your history. And with practice, you are able to elucidate a very good history that will enable you to elucidate the possible causes. And then history of liver disease is important. Family history of anemias, hemolytic anemias like sickle cell disease, which may present with splenomegaly in infancy, but later on the spleen becomes atrophic. Hereditary spherocytosis, the red cell membrane disorders, that's autosomal dominant in inheritance. So family history is also very important to look for hematological conditions which may be running in families. And then we take, is a history of lymphoma, history of leukemia, and so forth, trying to elucidate any of the infiltrative conditions. Investigations, of course, the most important is to do a blood count. You do a total blood count and a mandatory examination of the peripheral blood film. The peripheral blood film gives you valuable information. You can check for sickle cells, you can check for spherocytosis, you can check for malaria parasites, other red cell inclusions, and you can look at the morphology of the white cells, whether they are leukemic cells in circulation or not. If the platelets are reduced, you can confirm that on the peripheral blood film. So we get a lot of information by examining the peripheral blood film. And then we would do a bone marrow aspirate and biopsy. Again, this would be helpful in elucidating the cause. We can identify Leishmania donovani bodies, LD bodies in the bone marrow. We can examine the bone marrow and look for abnormal lymphoid infiltrates, chronic myeloid leukemia, chronic lymphocytic leukemia, that we can also pick up on the peripheral blood film, but we can do a bone marrow as well. And we can pick up Gaucher cells in some of these storage disorders from the bone marrow. Histiocytic disorders also we can pick up from the bone marrow and examination of the biopsy. Myelofibrosis, again, we can only make the diagnosis of myelofibrosis on a bone marrow biopsy. Splenic Aspirate is also a useful tool when it comes to investigations. It's a fairly easy procedure, but we have to make sure that the coagulation parameters and the platelet counts are normal for the patient. With a Splenic Aspirate, you can confidently make a diagnosis of leishmaniasis. You can make a diagnosis of Gaucher's disease and other infiltrative conditions. If there is extramedullary hemopoiesis, again, a Splenic Aspirate will enable you to make that diagnosis, because on the Splenic Aspirate, in extramedullary hemopoiesis, you may see hemopoietic activity. So there is erythroid, myeloid, and importantly, megakaryocytic precursors in the Splenic Aspirate, which tells you that there is extramedullary hemopoiesis. And then we have auxiliary investigations. You would do an ultrasound to estimate the size and volume of the spleen and see whether there are abdominal lymph nodes also involved that would point towards a lymphoproliferative disorder. So radiological investigations, ultrasound in limited resource facilities, or a CT scan in more in the advanced diagnostic facilities. And then we can do other tests to confirm the underlying disorder, whether it's liver functions and other tests, so forth, to confirm the underlying disorders. So this term hypersplenism, what exactly is hypersplenism? Of course, it's a consequence of an enlarged spleen, and by definition, it's a clinical syndrome with the following features. There's an enlarged spleen, cytopenia. So there is a reduction in the neutrophil count, there is a reduction in platelets, and there is a pooling of red cells, which causes anemia, a dilutional anemia. So, the spleen gets enlarged. The red cells, of course, will get pooled into the enlarged spleen. Even the platelets will get pooled. They are sucked into that enlarged spleen, so the circulating platelet count will be low. Red cells get also sucked in, so circulating red cells are reduced, and that results in a low hemoglobin level. And of course, the neutrophils will also get pooled into the spleen. So we have a reduction in all three cell lines, or any one of the three cell lines, depending on the degree of splenic enlargement. So cytopenia, reduction in platelets, red cells, neutrophils. When we look at the bone marrow in hypersplenism, the bone marrow is normal, or it may be hypercellular. So the bone marrow reacts to the pooling effect of the hemopoietic elements in the spleen by producing more red cells, more white cells, and more platelets. So megakaryocytic activity is increased, the megakaryocytes are increased, the red cell precursors are increased, and the white cell precursors are increased. And we may see also an increase in other cells within the bone marrow. The reticular endothelial cells may be increased within the bone marrow. We may see parasites in the bone marrow, and so forth. So when there is this pooling effect, the bone marrow is releasing cells into circulation to compensate for the pooling effect of an enlarged spleen. So we may have a premature release of cells in the peripheral blood. Reticulocytes, which are young red cells, may be increased. We may see a left shift in the granulocytic series in the peripheral blood, and we may see some large platelets, some large immature platelets. So when there is pooling of hemopoietic cells in the spleen, because the enlarged spleen will increase the transit time of all these cells in the spleen. They come into contact with this prolonged contact with the splenic macrophages, and therefore the survival of red cells and platelets is reduced. Apart from the pooling effect, there is also a reduction in the lifespan of these cells. So I just wanted to finish off by talking about hyposplenism, although it was not in the scope of the lecture. I thought I would just mention it as the other end of the spectrum. We have hypersplenism, but occasionally we may see situations where the spleen is not functioning. And we then call that hyposplenism. And that's a list of the conditions. The most important there is sickle cell anemia. Sickle cell anemia because of sickling. Sickling in the microvasculature, there is a splenic infarction that takes place, and eventually the spleen becomes atrophic. And when the spleen becomes atrophic, the immunity goes down. When we see the presence of red cell inclusions in especially what we call Howell-Jolly bodies in the red cells. And in other conditions like thrombocythemia, that is where the platelets are produced in large numbers, that causes again infarcts of the spleen. A massively enlarged spleen will outweigh its blood supply, and we get infarcts of the spleen, and that's what happens in myelofibrosis, malaria, and lymphomas. And various other conditions. Another important condition for hyposplenism are the autoimmune diseases, again affecting splenic function and its architecture. And certain gastrointestinal diseases like gluten-induced enteropathy, ulcerative colitis, and Crohn's disease. These are also associated with hyposplenism by some unknown mechanisms. And again, when the marrow is infiltrated by lymphomas and other infiltrative disorders, the splenic functions will reduce and present as hyposplenism. And again, certain drugs may also cause that. Irradiation to the spleen, or when there is splenectomy, which is done for various reasons. There may be spontaneous rupture of the spleen that we see in infectious mononucleosis. The spleen just ruptures, sudden enlargement of the spleen, and the capsule just gives way and the spleen ruptures. And then the spleen has to be removed. Or following a road traffic accident, when there is injury or rupture of the spleen has to get removed. And this may also present with hyposplenism. As I mentioned, these are some of the common conditions where you get hyposplenism. Congenital absence of the spleen is rare. It may be accompanying other organ malformations. I mentioned about the age when the spleen becomes atrophic in the 6th decade of life. And if the blood supply is affected to the spleen, or if there is fibrosis in the spleen, then we get hyposplenism. And we know there is hyposplenism when we look into the peripheral blood film and we see Howell-Jolly bodies in the red cells. That is an indication, because as you're aware, when the red cells are released from the bone marrow, they do not have a nucleus, but there are remnants of ribonucleic acid in the cytoplasm of the red cell, which is removed by the spleen. These remnants of RNA are removed by the spleen, but when the splenic functions are not there, or if the spleen is not functioning well, then these RNA remnants remain and present as Howell-Jolly bodies. Membrane disorders also occur, like acanthocytes and crenated red cells. The red cell count, the reticulocyte count is increased. These are young red cells which are being produced by the bone marrow. So reticulocytes may be increased because the spleen is not removing the remnants of RNA. So when we do a reticulocyte count, it's raised, and we may see isolated nucleated red cells in circulation in hyposplenism. So that's the last slide. If there are any questions, or if there's something which is not clear, I can attempt to clarify it. We can check the chat box. What's the difference? Joshua is asking us, what's the difference between hypersplenism and splenomegaly? So we've talked about splenomegaly, which is an increase in size of the spleen. And it's not always accompanied by a reduction in the red cells, reduction in the white cells, and a reduction in platelets. So when the spleen is enlarged and there is thrombocytopenia, there is anemia, and there is neutropenia, that is hypersplenism. That is a consequence of the splenomegaly. So not all splenic enlargement will present with hypersplenism features in the peripheral blood. It's usually massive splenomegaly which will present with hypersplenism. That is a reduction in the counts in the peripheral blood. And when we look at the bone marrow, it's actually hyperactive. So that's the difference between hypersplenism and splenomegaly. How do autoimmune diseases like rheumatoid arthritis or SLE cause both splenomegaly and hyposplenism? So that's a very interesting question from Aisha. That's a very difficult question, I must say. How do autoimmune diseases like rheumatoid arthritis or Sle cause both splenomegaly and hyposplenism? So splenomegaly, which we see not always with in all cases, but when splenomegaly is present with rheumatoid arthritis, that is Felty syndrome, which I mentioned earlier on. The hyposplenism that we see, I mentioned some disorders affecting the gastrointestinal tract, like Crohn's disease and Whipple's disease. Those have an autoimmune basis, and for unknown reasons, they affect the spleen and cause hyposplenism. So that could be a relationship between SLE and hyposplenism, or autoimmune diseases and hyposplenism in those particular conditions. But in the initial phase of the disease, hyposplenism is not a feature. It is seen only in a few cases of autoimmune diseases, particularly when the GIT is affected. Again, in autoimmune diseases, you could have, when it's pansystemic, you could have autoantibodies against the splenic antigens or the splenic cellular components, and that can damage the spleen. Another question from Niharika. When we are trying to define splenomegaly, do we use the weight measure or more than 1 gram of the length measure or more than 20 centimeters? Now, you can assess the degree of splenomegaly using your clinical acumen and see the extent of the splenic enlargement, whether it's just palpable below the left hypochondrium, whether it's going to the umbilicus, or whether it is going into the right iliac fossa. So from the umbilicus to the right iliac fossa, I would call that massive splenomegaly. A few centimeters below the costal margin, say 1 or 2 centimeters to the umbilical cord, that would be moderate. And mild splenomegaly is when it's less than a centimeter below the costal margin. We can use radiological methods to estimate the size of the spleen. So they talk about splenic volume when they do the radiological investigations, and based on that criteria, then you can also classify whether it's mild, moderate, or massive splenomegaly. But in terms of length, it is all the criteria I gave you at the introduction of my lecture for splenomegaly. Yep. I think those are the only questions I can see. Yeah, those are the only questions I can see. If there are no other questions, we can conclude. Tumir, we can conclude.
Yes, doctor. Thank you.
Yeah. Now I've sent you the presentation on email.
Yes.
So you can circulate it to your class. Okay.
Thank you so much.
Right.
No problem.
Okay. Right. All right. Good evening.
Okay. Have a good evening too, doctor.